Welcome to the 30th annual John H.P. Maley Lecture. In 1996, the Maley Lecture was established to honor a member of the American Physical Therapy Association who has made a significant contribution to the profession in the area of clinical practice. I am proud to introduce this year's lecturer, Dr. Nancy Bloom. Dr. Bloom is a professor emerita of physical therapy at Washington University School of Medicine. She received both her master's degree in occupational therapy and her clinical doctorate in physical therapy from Washington University, where she worked as a clinician and educator for more than 4 decades. Dr. Bloom primarily focuses on the hip and lumbar spine in clinical practice, education, and research. She also plays a key role in integrating diagnosis and critical thinking across the curriculum and converting it into a competency-based format. She has authored more than 20 peer-reviewed articles and gives presentations at the local, state, national, and international levels. Dr. Bloom received the Outstanding Service Award in Education from APTA Missouri and the Henry O. and Florence Kendall Practice Award from the APTA. She also serves as a director on the board of APTA Orthopedics. She is a strong proponent of the movement system for physical therapy and has taught numerous continuing education courses on the topic of diagnosis and treatment of movement system impairment syndromes. In today's lecture titled, "Let's Do It, Fully Embrace Movement as Our Identity," Dr. Bloom promotes the movement system as more than a framework for physical therapy. She believes that it's our unifying identity, our North Star, our responsibility. But it's better to hear this directly from her, so please join me in welcoming Dr. Nancy Bloom.
Thank you, David, and thank you to the APTA for honoring me with this award. I'm truly humbled and grateful for this recognition and opportunity. Today, the title of my presentation is Let's Do It, Fully Embrace Movement as Our Identity. I'd like to thank the individuals responsible for my nomination, starting with Dr. Gammon Earhart for coming up with the idea, to Dr. Barbara Norton for leading the nomination, and to these respected individuals for writing the letter of support. I'd like to thank my family. My dear late parents got this all started. Speaking about foundations, they were rock stars. Also, I wouldn't be here without the support of my husband, Peter, and the immeasurable ways that each person in my family has contributed to my life. I'm fortunate that several of them are over there tonight to join me. I'd like to share a few words about my journey to this day. About 15 years ago, the director of the physical therapy program, Dr. Susie Dusanger, recommended that I branch out of the Washington University bubble and get more involved in the profession. This was great advice. Since then, I have enjoyed participating in APTA and in APTA Orthopedics. I wish I had started earlier. Collaborating with people from all over the country has been an eye-opener. This is such a great conference, an example of individuals who embrace the profession and try to make a difference. I want to thank you for your contributions. A year ago, I was in New York City with my husband, and we saw this beautiful church and decided to go in and take a look. Well, while I paused for a moment while I was in there to ask for some guidance for navigating my retirement, which is about to start in July. I then walked outside and got an email from Roger Herr indicating that I had received this award. Well, I was shaking with excitement and disbelief, and I knew what I'd be doing for the next year. I admit it's been a bit scary, but the journey has been great, great fun. I've enjoyed talking to and learning from many of the previous Maley lecturers, leaders at APTA, colleagues, and even architects. More about that later. As you've heard today, John Maley made significant contributions to our profession as a friend, advocate, and generous supporter. I'd like to share a story with you that exemplifies his character and why we choose such words to talk about him. I heard this story from Dr. Anthony DeLito, who was a friend and colleague. I feel like Tony and I grew up together in our professional lives. In 1995, John Maley began his term as chair of the foundation, and while the foundation was under the umbrella of the APTA, they functioned separately. Although John supported the purpose and importance of the foundation as a businessman, he could see that they were on a path to insolvency if something wasn't done right away. He knew he wasn't going to let that happen, let the foundation fail on his watch, so he sounded an alarm, if you will, to make something happen. He reached out to the leaders of the research section, Dr. Lynn Snyder-Mackler and Dr. Tony DeLito, to get some help. They met the very next day. The three of them met at Tony's home to discuss a plan to turn things around for the foundation. That plan had to include the APTA. So Jan Richardson and Jane Snyder, the vice president, flew to Pittsburgh, and this group of 5 met at a Pittsburgh airport hotel and created a plan to work together to support the foundation to gain financial stability. John was visionary and he was practical. His willingness to have difficult conversations and work as a team to get the job done allowed the foundation to stabilize and grow into the solid organization that it is today. What a great example of working together for the greater good. I am honoring this story today as part of my title. Let's Do It is my way of sounding an alarm and expressing urgency that we need to work together to move our profession forward. The John H.P. Maley Award was established in 1996, and it's exciting for me to point out that the first recipient was my good friend and colleague, Dr. Shirley Sauerman. As many of you know, she is still very passionate about our profession. I have 3 primary objectives today. The first is that you will enhance your understanding of the progress and challenges experienced by our profession regarding movement and diagnosis. The second is that you will embrace our role as doctors of physical therapy and movement system experts. And third, leave here empowered to work towards unification in facing our remaining challenges. I want to start with a positive and exciting example of progress on the topic of movement and one of my general themes today of working together, our own professional headquarters, the APTA Centennial Center. The leadership worked with our vision that movement can transform society and charged the architects to create a building that represents movement, togetherness, and collaboration. I bet you wondered how I was going to work architects into this, and so now you need to wonder no longer. I had a chance to talk to the lead architect at Gensler, and he told me that in designing the building, reward movement was the mantra. He also said that evoke body was kind of abstract, but they wanted the architecture to feel like a well-balanced body, grounded and proportional. He used this analogy in presentations. If you go to the dentist, you expect to see a good set of teeth. Look what they were able to do. The building invites movement. It's across the street from a walking, cycling, and running trail. Cycling is supported by providing storage for your bike and a place to shower. Inside, there is a beautiful stairway, positioned front and center, inviting you to move rather than take the elevator. Your movement is then rewarded with this lovely outdoor space with a view of the Potomac River. There are several beautiful meeting spaces to encourage working together, and there is also a community wall comprised of colorful panes that evoke movement, which contain the names of thousands of people who donated at least $10 to the campaign for future generations. The association delivered a building that achieved a coveted 3-star ranking with the Fitwell standard. For the purposes of my presentation today, I want to emphasize this link between the foundation of our physical structure to our professional identity as movement experts. If the building got it right, so can we. Movement and diagnosis, when did it all start? Well, in 1975, Dr. Helen, in the Mary Macmillan Lecture, Dr. Helen Hislop urged us to identify our professional body of knowledge. She posed that we rally around the science of pathokinesiology, or the study of abnormal movement. In 1983, there was a call for the profession to identify as movement experts. And then, in 1984, the House of Delegates adopted a policy permitting PTs to establish a diagnosis within the scope of their knowledge, experience, and expertise. Note that this was more than 40 years ago. Many of you were probably still in diapers. Beginning in 2013, APTA led several activities focused on the movement system and diagnosis. First, APTA adopted a vision statement that included the term movement: transform society by optimizing movement to improve human performance. To support this vision statement, guiding principles were adopted. Among them was an identity statement. The PT profession promotes the movement system as the foundation for optimizing movement to improve the health of society. Note that the statement included movement, but also a new term, the movement system. This slide is an abbreviated version of a timeline that's published by APTA, which describes sponsored activities related to the movement system from 2013 to 2020. Embedded in this work were also activities related to diagnosis. During this 7-year period, the definition of the movement system was adopted and updated. There was a commitment to classification and development of diagnostic criteria and labels. A movement screen was developed and incorporated into the annual PT visit. The movement system was included in the Guide for Physical Therapy Practice and the resident competencies. The timeline ends with an invitation for interested parties to develop and publish diagnostic or classification labels. These activities that I just described significantly impacted me. I believe the movement system provides us with the solid foundation for optimizing movement. Movement is what we see. It is our professional lens. Just like a dermatologist can't look at anybody without seeing their skin, or a hairstylist can't look at anybody without looking at their hair. We are seeing movement. I know you've all experienced being at the airport, or even better, a beach, where you can look around and can't help, to see the movement around you. But I'd like to, I'm off my little kilter here. I've never used these teleprompters before. But I'd like to emphasize that although we observe movement, it's the movement system that provides a foundation for understanding the movement we see. I'd like you to watch this video. Now you can see that something is wrong with this movement during left single leg stance. However, it is the physical therapist who is identified as the professional who has the knowledge to explain the biomechanics and the contributing factors to the suboptimal movement and provide an appropriate treatment plan. In other words, many people can recognize deviations in movement, but they need the physical therapist to explain them and provide an intervention. PT professionals seem to agree about our identity as movement experts, but there are challenges. Is it in the terminology? Is the concept of the movement system too broad? Is it that we have different views about diagnosis? Or is implementation challenged because we are functioning in silos? Let's start with terminology. Although many terms need clear definitions for a common language, in this case, I'm starting at the top with movement and the movement system. How do these terms fit together? Simply put, movement is the output of the movement system, and in turn, movement impacts the system. How do we define the terms? As regarding the movement system, APTA has adopted a definition. It is the integration of body systems that generate and maintain movement at all levels of bodily function. Human movement is a complex behavior within a specific context and is influenced by social, environmental, and personal factors. The written definition states the integration of body systems, but it does not state what the systems are. However, the visual representation does identify body systems believed to be key for movement. You can see them in this figure on the periphery. Regarding movement, several definitions exist in dictionaries, and you Google it, you can find several definitions, but the profession has not adopted a definition. This mismatch between the written definition and the visual representation may lead to confusion. Also, the lack of an adopted definition for movement may result in unintentional mixing of the terms. Let's now discuss whether the concept of the movement system is too broad. The definition of the movement system is a general one. It is meant to broadly describe the concept and function of the movement system. The broadness of this definition allows our understanding and management of movement at a variety of levels and across various areas of practice. So yes, it is a broad definition, but I believe it is useful. Here are some examples to support my belief. Knowledge of the movement system provides us with the ability to optimize motion for an athlete. This could be after an injury and return to sport, or performance enhancement in someone who has not had an injury. The knowledge also covers our ability to understand movement in those with pain conditions. This person is a construction worker who had pain between the scapulae for 2 years, but he was otherwise healthy. His imaging findings were negative. While we know movement and alignment normally are variable, we can see less than optimal starting alignment in this still shot. Initial observations include sloped shoulders and a prominence of the left scapular border. We can also see suboptimal movement during left shoulder flexion, which also increased his pain. I know, I can hear everybody. Our knowledge of the movement system, particularly the nervous and musculoskeletal systems in this case, guides us in performing additional testing to determine the primary movement problem and key contributing factors. A broad definition also covers the physical therapist's understanding of movement in those with health conditions or lesions in one of the primary body systems impacting motion. This person had a cerebral vascular accident. Our knowledge of the impact of a lesion in the nervous system helps us understand how movement might be altered. As we observe his gait, we can see that the right arm does not swing like the left, and the right lower extremity circumducts to advance the extremity. He is unable to isolate movement between the hip, knee, and ankle. Intervention may include providing a device to compensate for a loss of movement, such as you see at his ankle. Additional interventions to maximize functional independence and his activity level may be key. A final example is that a broad definition also covers our role in guiding individuals on the amount of movement or activity. Some people need to move more, and some people need to move less. We have the knowledge to prescribe the right dose. Another reason I like having a general definition is because I believe it provides a framework for understanding movement and a framework for guiding research, education, and clinical practice. I believe it is a system, though it combines the function of multiple systems. I consider it like this definition of the immune system: a complex network of cells, tissues, and organs, and the substances that they make that help the body fight infections and other diseases. It is a complex network just like movement is a complex behavior. I'd like to acknowledge Dr. Phil McClure, who was chair of the program at Arcadia University and gave the Maley Lecture last year. The title of his presentation was "The Movement System and Diagnosis, Are We There Yet?" This title, of course, piqued my interest, and I was thinking it could be my title, but he took it away. These comments related to my discussion of the terminology and the broadness and the definition of the movement system. In his presentation, Dr. McClure stated that the movement system is a foundational concept for physical therapy, practice, education, and research. I agree. He also advocated for an operational definition of the movement system. An operational definition specifies concrete, replicable procedures designed to represent a construct. Note, this is very different from the characteristics of a general definition I previously mentioned. I believe operational definitions need to be created to study the movement system, but it's the next layer. This is an opportunity to work together. I'd like to give a more specific example. Dr. McClure published an article in 2021 in the Physical Therapy Journal where he describes a 4-element movement system model to guide education, practice, and research. The 4 elements are passive motion, force, energy, and control. During various functional activities, qualitative analysis of movement during the tasks includes assessment of control, amount, symmetry, speed, and the impact of movement on the symptoms. He adds that these factors can be quantified, but start with observation and qualitative analysis. On the left here, you can see the model I just described. In the center, you can see an example from the APTA annual visit. And you can see that there are a variety of tasks here. And they provide guidelines for observing movement that include control, amount, symmetry, speed, and symptom alteration during the task. At Washington University, we adopted the movement screen and added a few tasks: forward bending, standing on one leg, and hopping. We used the same categories for observing movement during the tasks. I'd like to draw your attention to the similarities across these groups. We are so close. I also want to review the progress made by the APTA Neurology. In 2015, they established a movement system task force to develop a framework for movement analysis as well as develop movement system diagnoses. In 2021, Dr. Lori Quinn and the members of the task force published this article describing the framework. They identified 6 core tasks, which you can see have a lot of similarity to the tasks on the previous slide. Their framework added additional depth by including a 5-stage task analysis described by Dr. Lois Hedman and her colleagues. More specific definitions of the constructs of movement were also included. As you can see, similarity in terms are here again. Recently, the APTA Pediatrics adopted much of this framework and plans to add tasks that are more relevant for developing children. Progress is being made. I'd like to give a case example linking qualitative analysis of movement with the movement system. This high school student is an avid ice hockey player. He developed femoroacetabular impingement syndrome, or FAIS, and required hip surgery. He also had a history of low back pain. These images will depict a few of his movements 4 weeks after his right hip surgery. Let's observe movement during sit to stand. We can see that he completes the movement, but uses his hands to assist in both directions. His movement looks symmetrical, but a few subtle observations include that he has a little less control of that right lower extremity, especially as he returns to the sitting position. And he possibly has some uneven weight distribution. I know I need to perform a single limb task to gain more information. Now we will observe his movement during single leg stance. You can see that when he stands on his left lower extremity, things look pretty good. But when he stands on that right lower extremity, there's a significant deviation and loss of control. Given the recent surgery, force is most likely the element to explain the findings, and specific muscle testing of his gluteals is indicated. Now we will observe his alignment. Grossly, we can see that he has a forward head and increased lumbar extension with an anterior pelvic tilt. Now let's observe his forward bending and his return. No significant problems are noted with forward bending, but his increased lumbar extension shows up again in that final phase of his return. You will see it now that it's a little bit more in slow motion. This is the phase of the movement that also increased his low back pain. Further testing is needed to assess the length of his hip flexors and range of motion for hip extension, as well as his abdominal strength. Although further examination is needed, we already have a good idea of the key body systems impacting movement. For example, his integumentary system is involved because he has an incision that is still healing. The musculoskeletal system is involved because we know his soft tissue and bone are still healing. We suspect muscle weakness in his gluteals, and we can see that his alignment is faulty. The nervous system is involved because he has pain, and I believe his natural pattern of returning from forward bending is learned and not necessarily due to his hip surgery. This really demonstrates such a strong link between the musculoskeletal and nervous systems. The cardio and pulmonary systems are affected because of he is usually very fit and he hasn't been able to work out since his surgery, and so he's less fit than he was. And finally, the endocrine system in this case was not a problem and he is healthy. So I return to a statement I previously made. While many people can observe deviations in movements, especially in his case, single leg stance, the physical therapist understands the movement system and can explain the biomechanics and the contributing factors to those impairments. We need to be recognized for this knowledge. I'd like to quickly highlight some key points. The terms movement and movement system are embedded in our profession, and we need both. I provided reasons why a broad definition is useful, and I gave examples of progress being made by a variety of groups as it relates to the movement system during functional tasks, along with a case example. And now, moving forward, I'd like to make some recommendations. I'd like the association to consider updating the definition of the movement system to include the names of the primary body systems that impact movement. I think the movement system definition and the visual representation should match. I'd also like us to adopt a definition of movement for the profession. Clear definitions will reduce variability in the interpretation of these terms. Research is needed, so funding and agreed upon operational definitions will move us forward. And finally, let's work together to expand this movement system timeline beyond 2020. Thus far, I have placed an emphasis on the body systems that impact movement identified in that visual representation. After 2014, there was growing recognition that movement is influenced by social, environmental, and personal factors. These illustrations of the biopsychosocial model and the International Classification of Functioning Disability and Health, or more easily said, the ICF, both depict the influence of these factors on a person's health status. The expanded definition of the movement system in 2019 reflects this recognition. I'd like to point out that these models from the World Health Organization apply to all health providers. So what is unique about physical therapy among providers? It is our knowledge of movement and the movement system. It's why people come to see us. Dr. Terry Nordstrom delivered the Mary McMillan address this year at the Combined Sections meeting in Houston. The title of his presentation was "The Heart of Movement, What's Love Got to Do with It?" Of course, I love this title as well and really enjoyed his presentation. He gave us a call to action to improve the environmental and social drivers that affect movement. He provided interesting statistics about the influences on health outcomes. 50% of outcomes are influenced by social and environmental factors, 30% by health behaviors, 20% by the profession's effectiveness in diagnosing and treating movement disorders. I'd like to point out that all healthcare providers must be considered for that 80%. The 20% is our unique contribution to health outcomes. As we engage with clients, politicians on Capitol Hill, and healthcare providers, we need to keep our lens as movement system experts. I'd like to return to our case example. We will assume at this point that we've completed a full examination, and we will be reflecting on additional factors from those various body systems. But now it's time to give a diagnosis. The movement problems at the hip could be classified as a force production deficit, and this diagnosis could be enhanced by classifying the stage of severity. In addition, his low back pain could be classified as a lumbar extension syndrome. His social, environmental, and personal factors do not change his diagnoses. The label for his movement diagnosis does not depend on those factors. However, those factors do influence his prognosis, intervention, and outcomes. In this case, the positive factors such as a secure home, financial stability, family support, and high motivation were strong moderators for his prognosis, and he had minimal barriers to implementing his exercise program. I believe this is always, I know this is not always the case. So the diagnosis alone does not give a complete picture of the person, but it is necessary to identify. So since I've just mentioned diagnosis, I'd like to discuss the challenge of different views about diagnosis. As previously noted, physical therapists have been encouraged to make a diagnosis since 1984. Although there seems to be agreement within the profession that we should make a diagnosis, we are challenged by different views on the types of labels that we use. In 2004, Dr. Cindy Zaidi titled her Maley Lecture, Diagnosis Dilemma. In this lecture, she eloquently outlined the status of diagnosis in our profession. I will quote the last few sentences of her lecture, which still resonate with me today. We need unity in the diagnostic process and labeling. We need the language embedded in our peer literature. We need diagnostic subclassification, a process designed and implemented so that we can refine it with research on an ongoing basis. We need professional and public recognition. PTs need to own that movement system from the science to the practice. What a great summary. Some progress has been made after her call to action. Between 2006 and 2016, a series of meetings titled Diagnosis Dialogue were organized and led by Dr. Barb Norton and described in this guest editorial in our journal. A group of individuals, all with known interest in diagnosis, gathered. They represented a wide range of expertise, such as clinicians from various areas of practice, education, association leaders, journal editors, and researchers. This group continued to meet until 2016, when the association began to sponsor diagnosis-related activities. What a great example of working together to solve issues surrounding a topic that was not universally accepted. You notice that the APTA timeline ended in 2020. Well, what happened? The SPAC, or the Scientific and Practice Affairs Committee, was put in charge of reviewing all the diagnoses submitted by the membership. And even though there was a template, there was significant variability in what people were submitting. There was also a lack of evidence to support these diagnoses. So a decision was made to pass the torch to the sections and academies to define and study diagnostic categories relevant to their specialty. Some academies, such as neurology, pediatrics, and pelvic health, made real progress. For example, Dr. Patricia Sheets from the APTA Neurology and her colleagues described several movement system diagnoses for adults with neuromuscular conditions in a publication in 2007. And then in 2015, the same diagnoses were updated to better represent the pediatric population. And just last month, Laureen Cobb and her colleagues from the APTA Pediatrics published this consensus-driven perspective regarding the adoption of those same movement system classification systems. This is progress, but 3 out of 18 sections or academies is not enough to move our profession forward as a whole. Why the slowdown? I believe a contributing factor is the lack of consensus on the type of label to be used for diagnosis. Many prefer using a medical condition or a label suggesting the pathoanatomy. Others support the use of movement diagnoses or the use of the ICF classification system. Also, there's been a lack of funding and interest in researching diagnostic categories. And finally, section or academy leadership may have had other priorities. I think the charge, or after listening today, maybe recommendations and instruct, was passed on without accountability. I believe as charges are made, we need to be accountable, and the accountability needs to be built into the task to make progress and not be subject to the priorities or changes in leadership. Why do I support making a diagnosis of the movement condition? While the diagnosis of a health condition is important and helpful, it does not typically describe movement or fully direct our intervention. For example, people with the same health condition can move very differently. First, consider 2 people who have had a cerebral vascular accident. A lesion in the motor cortex will present very differently than a lesion in the cerebellum. The person with a lesion in the motor cortex may need to learn to compensate for the inability to fractionate movement, while the person with a cerebellar lesion may need strategies to simplify movement to assist with grading forces during a task. The examination will reveal the movement condition. Next, consider 2 people with a diagnosis of femoral acetabular impingement syndrome. Let's compare their final position of forward bending. You've already seen this young man who demonstrates optimal hip flexion and spinal motion in the final position of his forward bend. This young man, however, is far from achieving 70 to 80 degrees of hip flexion, and most of his motion is coming from the thoracic and lumbar spine. Again, the diagnosis of FAIS is helpful, but not enough, and our exam will reveal their movement condition. On the flip side, many people with different medical conditions have similar movement patterns. A good example is the diagnosis of hip adduction with medial rotation. A person with this movement diagnosis could have trochanteric bursitis, gluteal tendinopathy, iliotibial band fasciitis, low back pain, or snapping hip syndrome, to name a few. The teenager in these photos had a referring diagnosis of snapping hip syndrome. In her standing alignment, you can see lateral pelvic tilt, or right hip adduction, and hip medial rotation. When she performs a step up, the same movement occurs, and it was associated with pain and an audible snap. Of course, there were other findings that needed to be considered, but my main point here is that there can be a variety of health conditions or sources of pain with the same primary movement problem. While it is helpful to know the source of pain as physical therapists, I believe we need to label the results of our examination with a movement diagnosis whenever possible. Once again, I'd like to make some recommendations. I'd like us to keep movement in the forefront as we incorporate the impact of social, psychological, and environmental factors on a person's management, as we advocate to reduce environmental and societal barriers that affect movement, and as we determine a diagnosis. I'd like us to establish movement system groups Now, I know APTA is doing a new strategic plan, so I'm thinking this could be part of it. I see this at the association level with representation from all sections or academies, and I look at the organizational chart, perhaps it could be a board-appointed committee. And I think additional groups are needed at the section or academy level to advise, to implement the recommendations from the association, perhaps a work group. The names aren't as important as creating a structure that will live and remain over time. It gets at that accountability I was previously mentioning. I'd now like to discuss the last challenge, which is the impact of functioning in silos. If we step back, we'll start with education, and if we step back from practice for a moment and think about our preparation, we must examine our education. I believe we tend to function in silos within and across programs. This independent function creates variability in the knowledge and skills of our graduates. If our educational preparation is variable, how can we expect anything but variability in clinical practice? And since I'm trying to unify us around the concept of movement, let's examine how the movement system and movement are embedded in educational programs. I'd like to start with CAPTE. Those in education know it well, but those who do not teach in a physical therapy program, it stands for the Commission on Accreditation in PT Education. CAPTE has standards and required elements for accreditation. There are 7 standards, and each one has a number of required elements. A description is provided to guide the program in providing evidence of the compliance. Overall, the document is 46 pages long. Across the entire document, the word movement is included twice, and the term movement system is absent, not present at all. And when movement is mentioned in element 7A, it is combined with the word sciences. So it talks about movement science, and movement science is not the same thing as the movement system and movement. I believe this is an incredible disconnect between our vision and guiding principles and the educational guidelines. This disconnect contributes to variability and functioning in silos. Under element 7A, more detail is provided for guidance on topics to include in your curriculum to comply with the element. There are 27 elements, and at a quick glance, we can see the inclusion of several body systems and important sciences for the physical therapist's knowledge for practice. What I'd like to point out, though, is that each body system or science is mentioned separately. My concern is that we are learning about systems in silos. There is one item, body systems interactions, that suggests integration of body systems and gets us a little closer to getting out of our silos. I'd like to see more items guiding educators to increase time spent on integrating content across systems to better understand their impact on motion. A similar concern regarding silos and lack of integration is apparent in one of our major assessments for licensure, the National Physical Therapy Examination. Here is an example of a study guide. I think you can see that the body systems are again listed separately, and there is only one item on systems interactions. Again, movement and the movement system are absent from this document. This again supports my concern that we are learning and assessing in silos. How can we expect new graduates to know how to relate their knowledge to movement and the movement system? One solution might be competency-based education, because it fosters integration of content for both teaching and assessment. However, there is no guarantee that movement and the movement system will be the focus of that integration. One method to ensure movement is woven into the curriculum is to explicitly include movement in curricular threads. Examples of 4 threads that we have at Washington University are generation and control of movement, underpinnings of movement, diagnosis and management of movement problems, and moderators of movement. Having these threads fosters a link between content and movement. Movement becomes a guiding principle for determining content, and I believe it reduces the risk of teaching and learning in silos. So moving forward, I recommend embedding the movement system and movement into the CAPTE standards and the elements. And I would like to see more questions in the licensure exam on movement and the movement system. I would also like to see more elements, I would also like to see more elements, items, or questions focused on integration. How the primary body systems interact to produce movement, and how movement impacts the body systems, and how health conditions impact movement and vice versa. So I also suggest developing a set of criteria that identifies a movement system practitioner. Note that I said practitioner. We use the term movement system expert, but do you really think that graduates are movement system experts? It's not likely. Graduates are prepared as generalists, and they have a great foundation to build on as they become experts. Meeting a set of agreed upon criteria would provide a common foundation for professional growth and specialization. Finally, I'd like to address our role as doctors of physical therapy. It all ties into professional identity. I have the utmost respect for physical therapists who graduated before the clinical doctorate was available. And I know you provide value to your patients and to our profession. I also respect and value the contribution of physical therapy assistants. You are an important part of our team. These comments are directed to those with the clinical doctorate or those who are studying to get the doctorate. Almost 30 years ago, the first class graduated from Creighton University as doctors of physical therapy. And 2016 was set as the deadline for all programs to complete the transition to the DPT. There were also some post-professional programs available for those who were interested. This was a bold move and facilitated many changes, particularly in education and practice. Although many physical therapists today are DPTs, we are relatively young in this arena compared to other professionals such as medicine and dentistry. I'd like to mention something I find somewhat ironic. As in medicine, some physical therapy programs have white coat ceremonies. Few items of clothing are as tied to a profession as a white coat is to being a doctor. It's a symbol of professional expertise, responsibility, and commitment. This symbolism of the coat is strengthened by the professional oath taken by each class. Yet, after completing a rigorous program, most physical therapists do not introduce themselves as a doctor or wear a white coat. So I find it ironic that there's all this excitement surrounding the white coat ceremony, but in practice, the symbolism is lost. Maybe our relative newness in the doctoring world relates to this, but I have a concern that we are not using the title in our communication and missing an opportunity to be recognized for our expertise in the movement system. There may be multiple reasons for not wearing a coat, but one of them appears to be that the physical therapist's desire to make the patients feel comfortable as possible, to have open communication, avoid the white coat syndrome, if you will. So in the end, it's not really the coat, but the person behind the coat that really matters. The coat choice is yours, but the responsibility of our behavior as a doctor of physical therapy remains. Being a doctor includes a variety of behaviors, but I'm going to focus on a few changes in communication. I'm asking for a change so that we are recognized as doctors of physical therapy and movement system experts. I'll give you a few examples. A small but impactful change could be how you introduce yourself. This could be as a provider, an educator, a researcher, or when communicating with interprofessional teams, policymakers, or insurers. To help reduce anxiety and increase comfort, you could simply say, "Hello, my name is Dr. Nancy Bloom. Please call me Nancy if you'd like." First impressions are important. Another example is communicating a movement diagnosis. Explaining the diagnosis to the patient lets them know that you have figured out their problem and empowers them to make changes in how they move during the day. So changing behavior isn't easy. It's much easier to say, "I support a change," than to actually change your own behavior. So let's consider the lyrics from a famous song by Michael Jackson that focuses on change. Let's start with the man in the mirror, ourselves. In closing, I want to express again my deepest gratitude to APTA for this incredible recognition. It's a true honor to stand here today and advocate for embracing our movement as our professional identity. As I said, I believe that the APTA headquarters got it right, and so can we. And even if you don't agree with my vision of our future, I thank you for all your dedication and countless ways you continue to contribute to our field. Let's move forward together, empowered and unified, to overcome challenges, to create a future where our profession's impact on health and wellness is universally recognized. I think the title of the conference is aptly put for what I'm trying to say. We can advance together. Only if we advance together can we transform tomorrow. Please introduce yourself with pride and as a doctor of physical therapy, because it is your expertise in movement that makes you invaluable to your patients and society. Let's make Let's Do It not just a slogan, but a call to action, a commitment to collaboration, innovation, and relentless pursuit of excellence in all that we do. Thank you very much. Whew.